Stand by. This is your 1-minute warning to showtime.
Good afternoon, ladies and gentlemen. My name is Nirav Shah. I'm the director of the State of Maine Center for Disease Control and Prevention. I'm joined today with Commissioner Randy Liberty, the Commissioner of Maine's Department of Corrections. Commissioner Liberty and I are here to provide everyone an update on the COVID-19 status across the state of Maine for today, Wednesday, May 20th, 2020. And overall, Maine CDC is now reporting 1,819 cases of COVID-19 statewide. That's an increase of 78 cases since yesterday and marks the highest single-day increase since we've started testing for COVID-19. That being said, this increase is not a surprise. As expected, with increased testing comes increased cases. Just in the past few days alone, our laboratory here in Augusta has processed samples for Bristol Seafood, for Clover Healthcare in Auburn, as well as for residents of 100 State Street in Portland, for whom testing is being made available today. As we continue to move toward increasing the amount of testing that's available across the state, we do anticipate seeing continued increases in the number of cases statewide. That being said, these increases underscore the need for us to keep our public health vigilance up. Even though the virus may not be recorded in every single corner of the state, we know that it can spread. And thus, another reason for the increased number of cases is the continued transmission of COVID-19 across certain counties in the state. Overall, although there have been now 1,819 cases overall, there have also been 1,110 individuals who have recovered. And of those 1,819 cases, 417 are among healthcare workers. I'd like to report on two new outbreaks that Maine CDC has become engaged with. The first is at the Seal Rock Long-Term Care Facility, where we are aware of one resident and 2 staff members who have tested positive for COVID-19. As it turns out, our colleagues at the National Guard were already slated to be visiting Seal Rock, and we've accelerated that, so they will be there on Friday to provide fit testing for staff members there, not just at the long-term care facility, but as well as at the assisted living facility right next door called Atlantic Heights. We're also similarly aware of an outbreak at Woodford Family Services in South Portland, where we are aware of 2 residents and 1 staff member who have tested positive. I'd like to provide a quick update on the overall number of outbreaks that are outstanding, since we haven't visited those numbers in a little while. And overall, across the state of Maine, I'd like to provide a brief update on some of those outbreaks. At the Blue Star Home Care Facility, there remain a total of 5 cases, or are a total of 5 cases. At Bristol Seafood, there are now a total of 15 cases. At Chinbro Construction, we've identified an additional 4 cases associated with that outbreak, bringing the total number to 23. At Clover Healthcare, there have been a total of 4 residents and 18 staff for a total number of 22 individuals. In terms of the other, at Durgan Pines, there remains 2 residents and 3 staff members for a total of 5 cases. As for the other outbreaks in which Maine CDC has been involved, there have not been substantial changes. I'd like to provide an update next on the testing data across the state. Maine CDC, on a daily basis, has now received reports from nearly 80 entities across the laboratory testing spectrum who are regularly reporting results to Maine CDC. We want to make sure that we are being careful and methodical as we tabulate those results and report them out. We similarly want to make sure that we are subdividing the various tests that we receive so that we're painting an accurate and complete picture of what's actually going on with testing as it relates to COVID-19 across the state. So in that capacity, I'd like to review the latest test numbers and then provide a comparison as to how those stack up against last week's. Before I go into these numbers, one final prefatory note. As we discussed last week, Maine CDC is now following the lead of the US CDC in reporting the total number of tests that were completed, not the number of individuals who were tested. So the numbers that I'm going to be reviewing now are the total number of tests that have been conducted. And overall, Maine CDC has received reports of 40,609 total tests performed. Of those 40,609 tests, the vast majority are PCR tests. That number is 37,725. That's 37725. We are also reporting 2,884 antibody tests as well. Those numbers added together produce our total number of tests, which again is 40609. Just to break down the positives and negatives within each of those categories. For the PCR tests, there have been 35,450 negative tests and 2,201 positive tests. 74 of those tests have been indeterminate. On the antibody side, there have been 2,704 negative antibody tests and 177 positive antibody tests. 3 of the antibody tests have been indeterminate. I'd like to compare those numbers against where we were last week. In the past week, statewide, there have been 7,574 tests that have been run. Of those, 6,437, 6437, were PCR-based tests, and 1,137 were antibody-based tests. Basically, 85% of the tests that have been run across the state have been PCR tests, and about 15% have been antibody tests. That's a lot of numbers. We're going to have those numbers on our website pretty soon so that everyone can take a look at them, and I'll try to post them myself as well. But what do these numbers mean? That's the real question. Well, one of the figures that I've talked about at these meetings is our overall positivity rate. And compared to last week, our positivity rate is headed in the right direction. Last week, our positivity rate was a hair under 6%. With the latest numbers, our positivity rate overall is now down to 5.4%. To break that down even further, the positivity rate for PCR is 5.5% and 5.4% for serology, for a blended positivity rate of 5.4%. We still have a fair amount of road ahead of us with respect to getting that positivity rate down. But just in the past week, we've driven it down in statistical terms by 10%, from about 6% to down to 5.4%. We've still got more work to do, but with the expanded capacity at Maine CDC's own laboratory, we hope to see more and more tests being completed in the coming days and in the coming weeks. I'd also like to provide an update on some of the vital assets that Maine CDC tracks. In terms of the number of total ICU beds, there are 388, of which 167 are available. There are 316 conventional ventilators and 439 alternative ventilators. At present, 43 individuals are currently in the hospital, 12 of whom are on ventilators and 24 of whom are in intensive care. And overall, since Maine CDC has been tracking COVID-19, 231 individuals have been in the hospital at some point. Before we turn things over to questions, I'd like to just provide a quick update on some of our overall PPE and public health preparedness activities. Yesterday, I talked about a sizable number of swabs and viral transport media that were being shipped out. We simultaneously yesterday received a shipment of additional swabs and viral transport media yesterday. We received 14,000 foam swabs from Puritan, 5,256 microtest kits, and an additional 1,080 comfort swabs. Those are, of course, being inventoried and will be soon sent out to healthcare facilities across the state. The availability of these swabs and this viral transport media, as it's called, are essential. It's one thing for our laboratory at Augusta to be able to process a lot of tests, but tests don't just happen. They need to be swabbed and they need to be put into the right transport media so that they can be sent to Maine CDC for processing. The availability of these additional 14,000 swabs and the additional 5,256 test kits of transport media will greatly enhance healthcare providers' ability to draw those specimens and send them over to us. We're hoping to push those out very soon, certainly within the next day or two. And finally, a quick update on the fit testing activities that we've been undertaking with our colleagues at the National Guard. Overall, 1,068 healthcare workers across the state have undergone fit testing, and there are now at least 400 additional individuals who are waiting in the wings to also be fit tested. The National Guard has been a fantastic partner for us in this process, and we look forward to continuing to work with them as to get more and more healthcare providers across the state fit tested. So with that, we are going to turn things over to questions from our colleagues in the media. Again, I thank Commissioner Liberty for joining us. Commissioner Liberty and his team, as well as with the team at Maine CDC, have been working together on COVID-19 issues since at least February. And so I thank Commissioner Liberty for joining us today. And today's first question goes to Megan Torgeson from WMTW.
Thank you, Dr. Shaw. And if I would like to ask a question of Commissioner Liberty, if I can. My question is obviously related to the correctional facility in Windham. I understand that, from what I hear, that everyone associated with that facility or works in that facility has been tested. Are we expecting those tests to come back at what point? And if you could kind of run down the steps that have been taken to reduce exposure, because from what I understand, you don't think that this prisoner or this person inmate arrived with it, that it was already in the facility. Is that correct?
Good afternoon. It's a pleasure to be here. The question was related to testing and what the results, when we expect to get the results of the testing of the Maine Correctional Center's situation that occurred yesterday. We've been preparing, as Dr. Shaw said, for more than 3 months with the CDC, following the US CDC protocols for COVID response in a correctional setting. And I believe that the exhaustive planning process led by Dr. Ryan Thornell has really borne fruit. Yesterday, when we received our first COVID positive test, we went into action. And the leadership team and the employees that work at the Maine Correctional Center went to work to isolate that individual, to do contact tracing to determine exactly who that individual may have had contact with, and set the plan in motion. And it went very, very well. Yesterday, we tested 64 staff, and about 123 of our offenders. Today, we expect to test an additional 500 individuals, and that will complete the entire facility testing, both staff, contract employees, and our offenders. I expect to receive some of those results this afternoon and others in the following days. I do not believe that the individual brought the virus in had been too long, and we're tracking down now through the contact tracing methodology and working with the CDC to determine just the possibilities of what may have brought the virus in.
Great. Thanks, Megan.
May I have a quick follow-up? May I just quickly follow up? These 78 cases, being that it's the highest single-day increase, what we're saying is that, or what I'm understanding is that none of those 78 cases, new cases, are related to the testing at the correctional facility. Is that right?
That is correct. That is other than the one confirmed case.
One yesterday.
Yeah, but other than that, that is correct. That is correct, Megan.
Okay, thank you.
You bet. We're going to turn next to Emily Tadlock at WABI.
Hey, Dr. Shaw, my question's for you, actually. So you say today that we are at 5.4%. For anyone listening at home, what does it mean to go from 6% to 5.4%? Is that a huge step? You said in the past you wanted to get to 2%. That seems like a really long ways away compared to this small little, it seems small jump, but it may not be. That's why I'm asking for clarification.
Sure. So Emily asks about the context around the drop in our positivity rate from 5.9, almost 6%, now down to 5.4%. So Emily, here's how I think about that number. The first is setting it against the context of what the national positivity rate is, and as well as the positivity rate in other states. Nationally, the positivity rate varies, but overall, it's still hovering. Some estimates have put it at around 10%. In certain hotspot zones, the positivity rate is well above 15% in some areas. And even in certain very concentrated areas, even higher than that. So relative to our peers in other states and relative to hotspots, we are doing much better in terms of casting a broad net. Now, what is it going to take for us to drop that number even further, and what will that look like? Well, one of the necessary pieces of that was being able to expand capacity at our Maine CDC laboratory. Our current capacity now stands at roughly 1,000 tests per day. If we are able to now couple that with pushing out swabs and transport media, which we're doing as aggressively as we can, we believe that we can max out our capacity at our laboratory as well as lean on other laboratories in the state, such as commercial labs in other states as well as hospitals. If each and every one of those cylinders is firing, we believe that we'll be able to really get to a number that will get that positivity rate down to where at least it mimics what happened in South Korea, which is that 2% rate. We're headed in the right direction, but as you note, it will take some time to get there. But the addition of our expanded capacity as well as a steadier supply of swabs means that overall, when it comes to testing, we're cooking with gas now. Emily, did you have another question?
No, that's good. Thank you.
You bet. I'm going to turn next to, who do we have next? It's the Right Honorable Don Kerrigan next. Don may be out tending to his herd of llamas. We can come back to him. We'll turn next to Amy Brown at WERU.
Thank you, Dr. Shah. We've been told that in March there were about 1,300 tests that had to be stored in a freezer for several days when the state ran out of reagent. And a few of the people whose tests were involved in that received negative tests despite having symptoms of COVID. And they're wondering if that is the case and if the samples may have been corrupted by being in storage in the freezer for that period of time. And do you know if there was a higher than expected rate of negative results for tests that were held while reagents were waiting for those to come into the state?
So Amy asks about tests that may have been temporarily put into a freezer while they were being transported to an outside laboratory, LabCorp in this case, back in March. And Amy, those samples are put into a negative 30-degree freezer, which, according to the experts at the US CDC, really just it puts it literally on ice. It's not room temperature, so the viral particles don't degrade. It really does almost flash freeze it and put the sample in, as I think of it, like suspended animation. And so that when it's unfrozen, the sample has not degraded because it's just been flash frozen. According to the US CDC, there's no degradation as part of that process goes on, and we haven't detected a higher number or a lower number of expected positives or negatives from the samples that were frozen and sent to an outside laboratory.
Thank you. And as a follow-up, one of the people who was involved in that scenario is still experiencing symptoms several weeks later. Can you talk about the criteria for being considered recovered? And have there been people who've tested negative who, after having the disease, test negative again, but still have some of these residual symptoms that people are experiencing? And how do they know if they're still contagious?
So Amy asks about what it means to be recovered, and can someone continue to have symptoms and still be recovered? And part of the US CDC's criteria for what it means to be recovered is that your symptoms have resolved, and not just for a couple of hours, but for a period of several days. And during that time, you're not taking any medication, which might suppress your symptoms, even though they might still be there. But what's also possible in an era where there's known community transmission is that someone could have had a regular head cold a couple of months ago, and in the interim time period, perhaps have been infected by COVID-19 in their community. I think, Amy, for anyone who's still concerned, if they're still having symptoms, especially if they are in an area where community transmission is known to be occurring, or they've been in contact with someone who's a confirmed case, I think what the US CDC would recommend is that they call their healthcare provider before they go and visit, and leave it up to the healthcare provider to determine whether their symptoms are compatible with COVID-19 and whether they should be retested.
Thank you.
You bet. We're gonna turn back to Mr. Kerrigan. Don, are you back?
I am. Thank you very much. My apologies for the delay earlier. A question about, could we see continued outbreaks in nursing homes? The one in Auburn, I believe, seemed to grow quite quickly. What is it that's happening in these homes? My understanding was that all staff in nursing home and congregate care facilities are supposed to be screened daily. No visitors coming in, as we know. Medical staff screened. So how is the virus still getting into these places if we are indeed doing enough to check to make sure people are well before they enter?
Thanks, Don. So Don asks about what do we know about how the virus is finding its way into all different types of congregate care settings, whether it's a nursing home, a shelter for people experiencing homelessness, or any such type of congregate care setting. And Don, what I think what your question really highlights is how important this asymptomatic or pre-symptomatic transmission really is as part of the broader puzzle. I want to answer that by comparing COVID-19 to the influenza virus. The peak of when COVID-19 can be spread from one person to another is right around the same time, if not even before someone starts developing symptoms. So Don, even though, as you noted, healthcare facilities across Maine and other congregate settings are taking temperatures, things of that nature, there's still the possibility for some transmission to occur the day that someone develops symptoms or even the day before. And I think that's what we're seeing a lot in many of these nursing home and other congregate care cases, is that someone is developing symptoms, and on that day, they might still be interacting with folks, and that's the time at which they could be transmitting it. That's in stark contrast to the influenza virus, the virus that causes the flu, where the maximum time at which you might be transmitting it is after you are really sick. And by that time, most people are already laid up in bed. So Don, I think that the straight answer to your question is that the way that it's getting into a lot of these nooks and crannies across the state, nursing homes, shelters, is during or via this asymptomatic period where people are feeling fine, but they're actually spreading the virus. That's one reason that little difference makes it really hard to control from a public health perspective. Does that answer your question, Don?
It does, and I have one other question regarding the Chinbro, we'll call it that, I guess, Chinbro outbreak in Augusta. I know that you said yesterday that there were a number of people from out of state working at that job site, and that you're still investigating to see who may have brought the virus in and who's spreading it. First, do you have any update on that? But second, does that bolster your belief in the 14-day quarantine for non-essential people coming from out of state?
Well, so Don, I'll speak first to the investigation. On the investigation side, we are still interviewing many of the contractors, the individuals who worked on the job site, different subcontractors. What we've generally found is that the bulk of the individuals who are at that site were from the Northeast. As I've mentioned, we've detected at least one individual from as far away as Wisconsin, but the vast majority have been from the Northeast. And we have not yet detected whether the individuals who were affected at the Chinbro site brought COVID-19 to Maine or acquired it while they were in Maine. It's a very challenging question to answer because it requires us to line up in one single row the dates at which each and every person started experiencing symptoms, and then try to look at what their exposures were. The other piece to bear in mind is that although the construction site has been identified, there's also the possibility that many of the individuals may have been congregating together outside of the site. So we don't even know if the construction site was definitely the area in which transmission occurred. Those are the types of questions that we're looking at and answering. But Don, as it relates to the 14-day quarantine period, to be candid, it doesn't alter my view one way or the other because we don't know whether individuals brought it in or whether they acquired it while they were here. Without knowing the answer to that critical question, my view on the 14-day quarantine period doesn't really get affected.
Thank you.
You bet, Don. Thank you. We're going to turn now to TJ Tremble from ABC 7. TJ, your line's open.
Sorry about that, Dr. Shaw. I was muted and now I'm unmuted. Two questions. First one for Commissioner Liberty. Commissioner, has there been any consideration given to moving the prisoners who come back negative to other facilities?
Thank you, TJ. The question from TJ was, has there been any consideration of moving inmates that are tested negative to other facilities? The national best practice is to limit the movement of inmates from facility to facility. As Dr. Shaw just indicated, some may be asymptomatic at some point and may cause cross-contamination. We've had some really good success with the Maine sheriffs who've been willing to hold inmates that are actually that have been convicted of state charges, and we've been able to eliminate cross-contamination from the county jails to our facilities, and the same has been true with the state facilities. We haven't been moving inmates. It's national best practice that they shelter in place, and we'll take care of it in that manner.
Thank you. Dr. Shaw, this is from a viewer. The question is about the rural reopening and the fact that Kennebec County had more total cases and deaths than Penobscot County, and their question was, why would businesses in that county be allowed to open before Penobscot County? So
TJ's second question is around community transmission, especially as it relates to Kennebec County. One of the features of Kennebec County is that the bulk of cases have been associated with the Augusta Center for Health and Rehabilitation. And so for that reason, we haven't really detected community-level transmission in Kennebec County. It may be occurring, in fact, but because so many of the cases in Kennebec are accounted for by the Augusta Center, it hasn't met the threshold that we've set forth. But I'd like to be really clear with everybody, especially for everyone who's tuning in from Kennebec County right now. The virus is almost certainly here. And even though Kennebec hasn't been officially listed as a county where community transmission has been officially confirmed, based on what we've seen in other counties of similar size, similar population density, it's almost a certainty that COVID-19 is around and is transmitting. I really do urge everyone in Kennebec County to please go about your day as if COVID-19 were everywhere in the community. And I think, TJ, that kind of explains the difference to the viewer's question as well.
Thank you, sir.
You bet. I'd like to, before I go to the next question, correct something that I said a couple of moments ago in connection with a question from Amy Brown about the freezers that we place these samples in to flash freeze them, to put them in suspended animation. And that freezer is a -80 freezer, not a -30 freezer, as I said. Again, it's a -80 freezer, which again puts the samples in suspended animation such that when they are thawed, they are as if they were fresh. I'd like to turn to Isha from the BDN next.
Thank you, Dr. Shah. I have two questions today. My first one is, does the state plan to expand testing in correctional facilities, and will there be testing criteria, or will it be universal testing? And if you could explain your reasoning behind whatever decision is made. And the second question is about antibody testing. Does a positive test on an antibody test automatically count as a recovered case in addition to being added to the probable case count?
Great. Commissioner, do you want to tackle the first one, and then I'll hit the antibodies?
Sure. Isha's question was, do we plan in the Maine Department of Corrections to have each of the facilities have universal testing? At this time, we're doing universal testing at the Maine Correctional Center, but there's no plan moving forward in each of the facilities, and that follows the U.S. CDC recommendation. Thank you.
And Isha, as to antibody testing, an individual with an antibody test is listed in our probable cases. But however, they also have to have symptoms. So as their symptoms resolve, they are moved from probable over to recovered. I will turn next over to Dan Newman from the Maine Beacon.
Sure. Yeah, Commissioner Liberty, up until now, the DOC's policy has not been to broadly test incarcerated people, instead testing only symptomatic people. Is there, you just said that you're not considering universal testing based on the fact that the federal CDC guidelines don't call for it. Other states have done that. Could you explain more about the reasoning before why you're not doing universal testing?
Yes, of course. So Dan's question is, why aren't we using universal testing for all the facilities? I think that the important question here or the important thing to note is that we've been planning for 3 months, and we've been very, very successful. The team at the Maine Department of Corrections, the leadership team, the officers that work the pods and the units inside the 6 correctional facilities here in the state of Maine have been very successful in keeping COVID-19 out of the facility. We do monitoring for employees as they enter. We have excessive hygiene operating inside the facilities. We follow all of the PPE requirements as determined by U.S. CDC. We've had great success in what we've done so far, and I deeply appreciate all the efforts of my employees at the Maine Department of Corrections.
Great. Thank you, Dan. We will turn next to Brad Rogers at WGME. Brad, hope you're doing okay.
No, I'm doing fine, thanks. Couple of questions for you, Dr. Shaw. The first is, seems like whether it's a nursing home or work site or healthcare workers, doesn't seem to you like the bulk of these 1,800 cases are in congregate-type settings, and what more can we do to stop the spread?
So Brad's first question is around cases that we know to be occurring in congregate settings, not just in Maine, but nationwide. We've seen congregate settings account for the bulk of many of the cases, certainly the bulk of the outbreaks that we've been contending with. I think going forward, the question of how to manage congregate settings is going to be one that we're all going to have to face. Congregate settings are, by their definition, places where a lot of people are in close contact with one another. And I think going forward, there's going to be need to be a rethink of the way that these settings are engineered. For example, for nursing homes and long-term care facilities, will patients need to be spread out? Will there need to be more use of plexiglass to prevent individuals from potentially transmitting these things, whether it's influenza, COVID-19, or any other sets of viruses? In the immediate term, Brad, the challenge with congregate care really does go back to what Don Kerrigan noted, which is that there's folks who are coming in, there's folks who might be leaving, but they can often transmit the virus during this period before they have symptoms. Ideally, we would be able to detect that sooner rather than later. But right now, based on where the science is, that's the real challenge of avoiding this. The other thing we know about COVID-19 is that it does tend to spread more easily than other respiratory viruses, like the flu. And so when you have these two factors, you've got folks that can spread it before they know they've got it, and they can spread it more easily than other viruses. That really is a 1-2 punch, and it makes it very difficult, especially in congregate settings.
Okay, thanks. My other question is, there are reports of a new cluster of cases in China, which has prompted a new lockdown there. What can you tell me about that? And there's even talk of the virus mutating.
So Brad raises two notes. The first is reports that have come out about a potential new cluster of cases back in China, where the virus first emanated. We're aware of those reports. We've been following them. I got an update on one of them last night on a call with the U.S. CDC. We are aware that the health officials in China are undertaking a massive retesting regime to see if this virus is spreading in a new way. Brad, you raised the possibility that it might have mutated in some way. Although I know that sounds really scary, viruses do mutate. The question is whether the virus could mutate in a manner that makes it in some way more dangerous. And thus far, there hasn't been anything detected that would suggest a mutation that makes it more dangerous. But I'm aware that virologists, virus hunters across the world are studying that right now.
Okay, thanks.
You bet, Brad. We're going to turn next to Patty White over at Maine Public.
Thanks, Dr. Shaw. Yesterday you said that contact tracing was one of the primary hurdles that you need to jump over next with the coronavirus. I was wondering if you could elaborate a little bit more on what specific hurdles you're facing. You initially talked about hiring public health nurses and retired epidemiologists, and I imagine there's a limited supply in those professions. So I don't know if that's the hurdle, and if so, are you looking at other professions?
Great. So Patty asks for where we are on contact tracing. Patty, you're right. So stage one in expanding our contact tracing was redeploying individuals at Maine CDC to join up with our epidemiologists. Phase two was rehiring folks who had recently retired or stepped away from Maine CDC. Phase three, which is what we are working on putting into place right now, will entail hiring large numbers of individuals as well as using full-time volunteers. That process is underway right now. Thus far, and I would just like to underscore, we have not been, the rate of growth of the disease has not yet outpaced the number of contact tracers that we have available. But as we've talked about at these meetings, as we test and test and test more, we will detect and detect and detect more cases. So we're simultaneously and in that stepwise fashion hiring and bringing on more volunteers. The goal that we'd like to hit is just over 100, but that's again in stepwise fashion over the next several weeks as the number of cases increase. The other piece, Patty, that's been a challenge is on the IT front. Each contact tracer it probably talks to, on an average day, we're estimating maybe 10 to 20 individual cases, and each of those individual cases may be generating 10 to 20 names of people they came into contact with. Over a couple of days, that becomes thousands and thousands of close contacts that need to be monitored. Doing so requires a major IT frame shift. In the very near future, we'll be announcing our IT solution for keeping track of all of those contacts and the tracing that we are doing of them, how we're following up with them to check to see if they've got symptoms. For the ones who do, how we're providing other social services. We're going to be announcing that in the coming days. But Patty, as you can imagine, as everyone can imagine, that is a major IT lift to keep track of all that data and analyze it in real time. And we're going to have more on that very soon.
Can I ask you just one quick question to follow up?
Of course.
In terms of, hiring, are you looking towards other professions? Like I think in California, they're focused on librarians as potential contact tracers. Are you looking at any particular professions when you're to fill that role here?
We are. It's interesting, Patty. Patty asks about other professions. And I've had a number of individuals who have reached out to me personally across a diverse set of backgrounds and skills, offering their assistance as contact tracers. Some have been from the academic community. Some have been former corrections officers, bail bondsmen. I had an individual who's a retired U.S. Marshal reach out, and we are very thankful for all the interest and enthusiasm. In this situation, though, what we're really looking at and what contact tracing really entails, it's less about finding people, because in an era of a pandemic, people who have been close contacts of known cases, what we've usually found is that they want to talk to Maine CDC because they're worried about their own health. Nationally, at least as when some of the bigger pandemics have hit, the US CDC reports that the cooperation rate, if you will, between health departments and close contacts is well over 90%. So it's a little less about finding people and a lot more about keeping track of them. So Patty, we're looking at two different skill sets because there's two types of folks we're going to be hiring. One is what we're calling enrollers. These are individuals that are going to be making the initial contact with confirmed cases to generate that list of close contacts. That's not an advanced skill set. You don't need to have gone to public health school or have received advanced training in epidemiology. We're casting a broad net because that's going to be an avenue for a lot of people to join Maine CDC. There's a second category, though, that will require more detailed training in epidemiology. Those are going to be outbreak investigators. Those are going to be the ones that will continue to investigate the outbreaks in places like congregate care settings, the questions that Brad and Don have noted about why we're seeing more cases in congregate care settings. The ones doing those will be more like epidemiologists. So long answer, but that's where we're going on the contact tracing front.
Thank you.
And we'll wrap up today with Kevin Miller from the Press-Herald.
Thanks, Dr. Shaw. Two questions for you. I'm sorry if I missed it earlier. Do you have an update on the 100 State Street situation and how many cases there have been that have been proven there? And then I have a follow-up question after that.
You got it, Kevin. I'm going to just double confirm the number of cases. As of this morning, Maine CDC's records indicated, I believe, 6 cases, but we're gonna confirm that number so I don't give out misinformation. So we'll be in touch with you on that. So yeah, we'll get you the number as of 2:59 p.m.
Okay, great. One other question I have: we were looking at the demographics of the data, and it does seem that the percentage of positive cases among African American and Black residents has gone up and continues to go up. It's pretty high percentage. Do you have any explanation for what's going on there? Are these household members of, say, the workers at Tyson Foods, which has a larger immigrant population, or do you have any thoughts as to why we're seeing such a large number of Black or African American folks coming down with the disease?
So Kevin asks about some of the troubling racial disparities that have emerged in our data. And Kevin, the bottom line answer is that we've looked at that exact question in a couple of different ways. And what we've seen is that outbreaks like this don't so much create cracks in healthcare as much as they reveal the cracks in our healthcare system and our society overall that were there. What I mean by that is that the outbreaks, the disparities that you note, are accounted for by a number of factors that candidly I think have been there for quite some time across the United States as well as in our state. Some of them relate to the fact that the density of housing is quite high in lower socioeconomic status folks. That's one reason. The other is that their overall ability to access health care is lower. The third is that the jobs that they often have are ones that put them in the way of the virus and unfortunately don't allow them the ability to work from home. I think all of those factors combining together have generated this disparity. Candidly, it's just the latest in a long string of disparities where infectious diseases are known to affect individuals in lower socioeconomic status classes. Let me take a second to talk about what we're working on to try to right that. Just a few hours ago, we had the latest in a series of calls with the city leadership and the leadership of the immigrant rights communities in Lewiston. There are parallel conversations happening with those same groups in Portland as well. And what we're trying to do in both settings is three things. The first is greatly expand the ability to offer testing. Our colleagues at St. Mary's and B Street Clinic and CMMC in Lewiston have stood up testing sites and are going to continue that with more expansion coming on Friday. That's why those vials, swabs and vials that I mentioned were so critical. The second thing is culturally competent, culturally aware contact tracing. We want to make sure that no matter where a case comes from, be they from African origin, Southeast Asian origin, Latinx origin, we've got folks that can communicate with them so they fully know what public health steps are needed. The third element of our approach is safe isolation. Given the housing situation of a lot of folks, Kevin, you noted the close household contacts. That's challenging enough, but when there is a high number of individuals in a smaller space, the likelihood of household transmission is even higher. And for those individuals who are in that space, if they get infected, the livelihood of the entire family could be in jeopardy. So we're working on providing secure, safe isolation spaces at hotels and similar facilities, both in Portland and Lewiston. So individuals who have been diagnosed have a safe place that they can isolate and lower the risk of transmitting to family members. So Kevin, we're sadly aware of the disparities that you note. They trouble us. We always try to use a health equity lens as we're going about our work. And we're working with community leaders and leaders in the immigrant rights community. But to be candid, we've still got a ways to go there. Before we wrap up, I again would like to thank Commissioner Liberty. Anything else on your end, Commissioner?
I would just like to thank Dr. Shaw and his team. We've been working with the Maine CDC for 3 months now, and it's been priceless advice, and we enjoy our daily interaction and guidance from you, and we look forward to continue working with you.
Well, likewise, Commissioner, we applaud the fact that you followed the best available science.
Thank you.
We continue to look forward working with you. Commissioner Liberty and I, as well as Deputy Commissioner Thornell, we catch up with each other in a larger group every day, and we look forward to continuing to do that as we work through this situation, as well as accommodating all the testing. Thankfully, we've got expanded testing available at our laboratory so that the tests that you guys swab, we are able to run.
Thank you, Doctor. We
would have been in a different position just 4 or 5 days ago.
Right.
I'd like to wrap up on one note related to data. We have been working to expand the number and types of data that we are making available on Maine CDC's website. For example, as we look to expand the volume of testing that's occurring at the Maine CDC lab as well as other laboratories, we hope to, in the near future, be able to release on a daily basis the number of tests that have been conducted and the percentage of those that are positive, both for PCR tests as well as for antibody tests. So we look forward to being able to do that and provide that data very soon. As you may have noticed, that's a challenge. We receive reports on any given day from up to 80 entities across the country. We want to make sure that our data are accurate and paint a complete picture of the active outbreak that's currently ongoing, as well as the outbreak that may have passed through serology. We don't want to rush and put out numbers only to have to correct them later. We've been methodical from day one, and as we look to put these numbers on our website on a daily basis, we look to continue to keep that same data quality intact. The other number that we are looking to put on our website is breaking down the number of active and past cases on a more granular level. We're not sure what that level will be yet. Perhaps it'll be at the town level, perhaps something even lower than that. But we're looking for ways that we can do so in a way that balances the public's need to know what's going on with the right of privacy that individuals have. We're working on that and looking at ways that we can put those data out, again, in the coming days and as soon as possible. So I thank everyone for bearing with us as we've tried to balance For example, on the testing front, the need to be methodical, accurate, and complete, with the need to put out data on a timely basis. And on the number of cases, the need to balance privacy with the need to publish data so that everyone has a complete picture of what's going on. I thank everyone for their patience as we've been grappling with that. We've always wished to be as transparent as possible, as that is one of our core goals. We hope to have more updates on that in the coming days, but I do thank everyone for bearing with us as we ourselves are working through that. So we thank everyone for joining today. Thank you all. Have a great afternoon. We look forward to chatting soon. Thank you.